I'm going to tell you a story about a 41-year-old lady who came to the ED with mental status changes. She was diagnosed with a urinary tract infection and she was placed on antibiotics. Her physical exam overall was pretty unremarkable. She was alert to person, but that was really about it. Her labs showed that she had anemia and she had hematuria. Her platelets were pending. She was admitted to the internal medicine service and there were no beds available, so she became a boarding patient in the ED. The outgoing physician completed all documentation and really signed out care of this patient to the internal medicine physician. 4 hours after this patient arrived to the hospital, lab calls back with a critical result. Her platelets are now 4,000. This was not discovered. 16 hours after the patient's arrival to the hospital, the internal medicine physician noticed the patient's low platelets. The patient was then transferred to the ICU. She did have a plasma exchange, but she died from this adverse outcome. It clearly was a failure in handoff and communication. So what happened? A couple of things. First, the change of shift handover was really very brief. It was unclear who was responsible for the follow-up of this patient. Was it the ED physician who was just coming on, or was it the internal medicine physician who was actually the attending for this patient? When the diagnosis was made, the thinking really stopped. There was no independent evaluation by the ED physician who was oncoming. When this patient became a boarding patient, it was very unclear who was responsible for follow-up. The other issue was communication, and that failure really prevented ongoing treatment. When the unit secretary received that platelet result of 4,000, who did she tell? What's the protocol? What's the expectation in regards to follow-up? Who should have taken that critical test result? The unit coordinator did not remember who she told about that result.
Handoffs are about the transfer of care and critical information between one provider to another. A common misconception there would be that it only applies to change of shift between one emergency physician to another. But there are lots of opportunities for mistakes to happen in the emergency department. Clear communication about a patient can happen between an EMS provider and a nurse, between two nurses at change of shift, between two physicians, one a consultant or the admitting physician. So there's lots of opportunity for failures of communication. From the risk elements, there are a couple of critical factors. It really behooves the oncoming physician to do an independent evaluation. In other words, listen to the story, hear all the facts that have been ascertained, but approach the patient with a fresh set of eyes, if you will. The second step is really accessing and making sure that critical data points, critical information is communicated to the oncoming team or oncoming physician. When we see delays or failure, it is about frequently labs, x-ray results, or additional history which is obtained, such as an old EKG that's not communicated to the ongoing team. Fortunately, there are many new solutions and creative solutions that lead to improved communication and reduction of handoffs. A lot of them revolve around technology, so the ability to, for example, text or use social media or types of prompts, the ability to look at a tracking board where critical lab values are flagged and that information is communicated to the ongoing team. Some of the other techniques that are used are to decrease the amount of interruptions, particularly during the transfer of care process, and also to label and tag with colored areas or blinking areas, for example, on a tracking board, critical values or critical times. For example, the fact that a patient had been waiting in the emergency room 4 hours post-admission. Those kinds of cues and prompts lend themselves to technology, but there is no substitute for enhanced communication than face-to-face interaction. Face-to-face communication is critical in ensuring that handoffs are both timely and accurate in terms of information communicated. The best example of that is actually to do formal sign-out rounds and to bring the oncoming provider, introduce them to the patient, address any of the patient's concerns, and make sure that critical data elements are being followed up on. There's no substitute for looking somebody in the eye and having that communication and also having them repeat back to you what it is that you're concerned about and what things they need to follow up. A good example of that would be simply saying, hey, can you check on the labs on bed 5? I think they just have a UTI, as opposed to saying, This is a patient that arrived presented with acute urinary tract infection. However, on exam, some confusion was noted, and we're waiting for some critical lab values, including following up on the patient's anemia. In the end, handoffs are all about proper communication and transfer of care.